I'm Ezekiel Emanuel. I'm a professor at the University of Pennsylvania School of Medicine and Wharton School, and I work on areas of both bioethics and health policy. My work has long been on, for probably the last 20 years, about how to reform the American healthcare system, how to allocate scarce medical resources, how to think about the healthcare system realizing the goals we have for it: universal coverage, reasonable costs, high and consistent quality, equity across various lines, education, geography, income, and then finally having high satisfaction for physicians, other clinicians, patients, and the public. So the theme of a single-tier healthcare system versus multiple tiers, the ethics of it, how we accomplish it, how we prevent problems with multiple tiers, are themes that I've written on for a very long time. Well, I have two projects that are important. One is related to these GLP-1 agonists that are useful for diabetes, but also useful for obesity. They are scarce. The question is who should get priority. They're also very expensive, and the question is, are there creative ways we can finance the use of these drugs to actually bring the total cost down and get more people using the drugs? And so we've done a lot of research on the ethics of the use of these drugs, as well as how to think about financing them for healthcare systems, because many countries don't actually cover the drugs for obesity because the total cost is, in their view, too high, and we think this is a mistake. The drugs are pretty miraculous. A whole separate line of research that I'm doing is to think about why the American healthcare system is uniquely bad. Many European countries will have universal coverage, they'll have reasonably high quality, they'll have reasonable costs. Even though everyone thinks the costs are high, they're still reasonable at about 10% of gross domestic product going to healthcare, and people are very proud of their healthcare systems. In the United States, we have none of that. We don't have universal coverage. We have outrageously high healthcare costs. Quality in cancer is very high, but in everything else is pretty mediocre or bad. We have a lot of dissatisfaction with the system. And the question is, why is the United States so unique? What are the fundamental defects of the system? And if you change those defects, could you actually solve the problems of the healthcare system and get to a situation where we can actually achieve all 5 of the goals that a healthcare system has? I'm very excited about that. It's a book-length project, so it's taking a little longer. Well, I think the theme about should you have a one-tier healthcare system or a two-tier or multiple-tier healthcare system that we're talking about now, it's a theme we've been talking about for a very long time. And I actually think one tier healthcare system an ideal? I think we're wasting time. I think, excuse me. I think we have to focus on the question of there's going to be a basic tier. We call it essential healthcare or adequate healthcare that everyone's entitled to, and then people who either want to spend more, have the money to spend more, think health is the most important thing they can invest in, whatever their reason is, want to buy additional services, should be able to buy additional services. There are 2 big challenges. One challenge is what's in that adequate essential healthcare services. We have not defined it. We haven't focused on it because we've been debating this issue of, is it 1 tier or 2 tiers? That's not the question. The question is what's in the basic tier and what's the principle for including something or excluding something. I think that's the area, one of the areas we need to focus on. The other area is there may be ways in which, if people can buy more expensive care, they might undermine or compromise the essential tier that everyone's entitled to. How do you protect that? What are the circumstances where multiple tiers compromise the basic tier? And I think that is another area that we haven't spent enough time doing research on. So I think those are the two questions that really come out of this research, where we need much more concentrated focus over an extended period of time. Well, I think there are a lot of smart people, and I think focusing their attention on these important questions and putting aside what I think are some of the settled questions is important. I also think there's much more openness by public policymakers, people in government, people at the WHO, we can't cover everything. We have to cover only a certain number of things. And I think that means that what we do in bioethics is even more relevant to public policy. And I think that's something a lot of bioethicists haven't felt for a very long time. But I think actually we have a connection now between the policymakers, the technocrats, the economists, and the bioethicists, and they see the advantages of working together. And so I think that is the way we're going to make progress, and I'm optimistic that people are going to see it's very important to connect more rather than less. So I was asked to speak, give one of the brochure lectures about the ethics of a multi-tier system, and I was defending the argument that a two-tier healthcare system, where you have a basic tier for people, for everyone, and then people with resources or people who want to spend more on healthcare rather than spend it on travel or education or houses, can do that. I think it's ethical. I defended why it's ethical, because people should have freedom to spend their money however they want, as long as they don't compromise the basic adequate healthcare services that everyone's entitled to. And I think that was the theme. I think my view is the prevailing view at the Academy. I think there are disagreements about what's in the essential benefit package, but I was arguing against the idea that single-tier healthcare system is the ideal, is the best.